Good afternoon, everyone. I'd like to thank my committee. Okay, Josh, be good. Have to do a little teasing, a little pleasant things. I'm just giving you a hard time for fun. That's all right. Don't apologize. I was just playing with you. Okay, good afternoon. We'll call the meeting to the Health and Human Services Committee to order. I want to thank my committee for helping me get a quorum right away. Since there's so many other meetings going on, I appreciate the fact that you think that this committee is important enough to make it your priority. So thank you very much for coming. Let's do the easy ones first. House Resolution 502 with Representative Tanner. You have a new sub, which he brought to me ahead of time, that was just passed out, but you'll tell us that LC number. Have you got him on?
I'll be working off LC 371580S.
Representative Tanner, aren't you fairly new?
Yes, ma'am.
Who told you that you could sit at the table and you didn't have to stand up and, go through the firing squad over at the podium?
Well, I serve on Education, Natural Resources, and Intergovernmental Coordination. We've had a lot of committee meetings, so I was just following suit. If you want me to stand up, I'll be glad to, Madam Chair.
Well, I guess you're really tired after those, so we'll let you sit for this one.
Thank you. I appreciate you indulging.
Now I'm giving you a hard time.
No, that's okay. I'm used to that. I appreciate you taking time to...
Wait just a minute.
What's the number again?
It's House Resolution 502. It's LC 371580S.
It was placed to your right. Does everybody have the right number? Everybody's got it? Okay.
And just to let you know, the reason for the substitute is the Department of Behavioral Health, who I've been working with on this resolution, had some recommended changes. I've been working with the Majority Whip and also Bill Riley in the Speaker's office draft this language, so we wanted to make sure everyone was comfortable with it, and they've all approved the language. So that's the reason for the resolution. Just to give you a little bit of quick background, I know Madam Speaker likes us to be quick, so I will. 18 years in law enforcement, I come across a lot of individuals that had issues with mental illness, and on the forefront of providing these services and access to the mental health system. We've transitioned in Georgia over the past couple of decades from a hospital-based system to a primarily community-based and home-based recovery system. Many times we have issues with providing adequate access to these individuals to mental health care. Many of these individuals end up in our jails and our prisons with untreated mental illness. We need to protect the public, but at the same time, the forefront of my concern is protecting constitutional liberties. So what we have done is I've worked with the Department of Behavioral Health. As you know, they have closed over the past few years some of their hospitals. There's been lawsuits in this area. They're interested in seeing us move forward with studying this issue, bringing the experts to the table, and bringing forward new policy changes and legislation next year as a result of this study commission. What I'm asking for is the study commission to be made up of 3 members of the House, 3 members of the Senate, and 3 members appointed by the governor. 1 from the House and 1 from the Senate would be from the minority party. You'll see on the original resolution that Speaker Pro Tem, the majority leader, and the minority leader and others in leadership have co-signed onto this legislation, and I've worked closely with them in trying to draft the language to make sure that leadership, both parties, minority and the majority party, were comfortable with the language. If you'll look on the resolution, I won't go through every line of the resolution, but it in essence just lays out the case and the reasons that this needs to be studied and we need to provide adequate access. And on lines 23, working with the Department of Behavioral Health and Commissioner Berry, who's an outstanding individual and been very good to work with, we drafted this language of specific things we're going to be looking at. And I'll be glad to answer any questions, but primarily the idea with providing this access is currently in our current system, we're pretty much dealing with these individuals once they reach crisis mode. That means they're in our jails, they've committed a crime, law enforcement's responding to an issue. So many of our instances that occur, you're hearing from people that say, we knew this person had an issue, we knew there was problems, we'd been called out to that house numerous times, but there was just not anything we could do about it. What we're trying to get to is trying to find ways to intervene prior to the crisis point. I don't have the answer to that. I don't sit before you and claim to have the answer to that. I don't think any of us do. But by bringing all the experts to the table and working with Commissioner Berry and his staff and with the other experts that can be appointed to this committee, I feel like we can bring positive change to our mental health. And if you'll notice from the original bill, it was more broad. In the original resolution, we were looking at schools, school culture, how schools are built for safety, and we felt like it was important to narrow the focus down to primarily focus this study commission on mental health, and that's where we're at today. So, Madam Chair, I'd be glad to answer any questions anyone has.
I'm glad you got that correct, because there is no way I would want to be the speaker and have to herd a bunch of cats like we are. It's quite a job. Who mewed? Okay. So, and the other thing, sitting back there behind me on the floor, have I not taught you the value of brevity? This is a House resolution. You almost talked it to death. We're going to have to work on, if it passes out of here, we're going to have to work on your presentations. You get it out of rules.
You'll keep me straight, I'm sure.
Okay. Questions? Who do we have here? Okay. Representative Mitchell. This is your first time to come to our committee, so,
yes, ma'am.
You know, if you pass this test, you might not have such a hard time next time.
Thank you, ma'am.
Madam Chair, my button was pressed inadvertently.
Okay. Representative Kidd.
Yes, ma'am, thank you. I'm very, very much in support of what you've got here. We've tried something in the past, and as we know, the situation we have now is that if we were able to get the young man from Connecticut in to see a psychiatrist in Georgia prior to the crime being committed, we've really got no place to put him. They've closed all of the hospitals per se around the state, and our jails have become the mental health facility in the state, and overcrowded with mental health type patients. I very much support this, and I hope it goes forward and we can get something done.
Thank you, Representative Kidd.
I don't see any other questions. I have no one signed up to speak on the bill. Did anybody not get on the sign-up sheet? Okay. What's the committee's? All right, we've got a motion to pass. Do I have a second? We have a motion and a second. Is there any further discussion? No further discussion. Then everyone in the favor of the passage of the substitute to House Bill 502, that's LC 371580S, say aye. Anyone opposed, no? Well, sounds like you're getting out with an easy pass this time out of Health and Human Services.
Thank you, Madam Chair.
You're welcome. Okay, let's call House Bill 332, Representative Williamson. Yeah, of course. You're not a freshman. I just had to give him a hard time, just a little bit. And he sits right behind me on the floor.
Well, thank you, Madam Chair, members of the committee. I'm Bruce Williamson, State House 115, representing Walton County, Georgia. And with me today is Jim Cleghorn, who's the Executive Director of both the Georgia Board of Nursing and also the Georgia Board of Examiners of Licensed Practical Nurses. The bill I bring before you today is House Bill 332 by committee substitute. It should be in your folders, and that substitute number is LC 212171S. What this bill, what we're attempting to do in this bill is combine the Georgia Board of Nursing with the Georgia Board of Examiners of Licensed Practical Nurses. Mr. Cleghorn serves as the executive director, as I said, of both of these boards. This request comes by unanimous consent of both of the boards, all members of both boards. And what the bill does is, we would be, and I've got a, if you want to follow me along on the bill, Section 1, lines 16 through 17, sets the dates that the boards will be officially combined. Lines 26 through 28 defines the procedure that would happen if a board member changed employment, which is important to the professions that are various nursing educational backgrounds, I guess, professional backgrounds that are being represented on the board. Lines 34-40 defines how many board members will serve, and currently both of the boards total 15 members, and this will reduce the number to 13 members, and there'll be a small additional savings to the state of Georgia as a result of that in terms of meeting fees. And also it provides for the meeting and board officers in lines 52-53. Section 2 outlines the general powers of the newly reconstituted board. Section 3, line 116, confirms that the newly combined board will be known as the Georgia Board of Nursing. Sections 4 and 5 simply dissolves the current LPN board. And then Section 6 recites the new board's authority to issue temporary permits to nurse applicants until their full examination occurs. And this authority was given to the current board, so this is just reciting that authority again for the new board. And that, ladies and gentlemen, members of the committee, is the intent of the legislation, and I'd be happy to answer any questions the committee might have.
Questions from the committee? Well, I think I have a question, and it's probably the reason that Mr. Claycard's here, and he can answer it. You know, over the past few years with the budget cuts, there's been a severe restriction on who you can employ and the help you can employ to help these boards. And if you can explain to me really how putting the two boards together, taking off two board members, is going to make it easier for the big board to work, I would appreciate that.
Thank you, Madam Chairman. I appreciate the opportunity to address that. The bulk of the work, both licensing and disciplinary, is handled by board policy, and it's done by the board staff. The staff is the same for both of those boards. The same members work for both of them. And so the amount of work is not going to change on our end. It's not going to be an increased workload. As far as the board becoming more efficient working with those cases, by having the larger board, we would be able to split into more committees. The board would be able to accomplish more in a 2-day meeting period instead of just having one board sitting trying to have the whole board review all of the cases. They'd be able to split up, review it, and then bring it all back together at the end of the board meeting for a ratification by the complete board.
Okay, so you're saying now that really the primary work on issues is done by staff already.
Yes, ma'am.
So it's the same staff, so therefore they're going to just continue to do
Yes, ma'am.
what they have been doing, so that there's no problem with the boards. There's no problem with the RNs on the board having an LPN sit in and help decide disciplinary actions for the RNs, and there's no problem or concerns on the LPNs on the board, you know, having the RNs.
None of those have been addressed to us. Georgia is one of 4 states that does not have a combined nursing board, and all the other states have boards that are comprised of both RNs and LPNs. Certainly, when it comes down, if the legislature does pass this and we are combined into one board, the LPNs would be reviewing LPN cases and the RNs would be reviewing RN cases. However, when it comes time to vote, the full board would be able to vote on that.
Okay, I think somebody explained to me, you can verify this, is that often if an LPN is being disciplined, that the board often needs input from maybe her RN supervisor who might not have been doing their job and supervising correctly, or there might be some interchange between, you know, that where the board would need to gather information either from an LPN or from an RN, and that's one of the things that's going to be corrected.
I'm not aware of an instance where we've had to discipline both the RN supervisor and the LPN. During an investigation, there may be times when we have to obtain information from the RN supervisor, but I'm sorry, I'm not aware of any instance where the board would have taken action, the LPN board would have taken action against the RN supervisor.
Oh, no, I didn't mean they took action, but
Okay.
that they just needed input from both.
Yes, ma'am. Again, it could have occurred during the investigation process if there was something that was, and then the LPN board could have referred the case regarding the RN back to the RN board.
And so this will help it as far as the
Yes.
timetable and help bring quicker resolutions to the...
That is certainly our desire.
I mean, because one of the problems we're hearing, and I think we have the chairman of the board, Mr. Cranfield is chairman of the Board of Nursing. We're hearing all sorts of problems about lack of funds. Do you have anything that you would like to add to that it's really a problem as far as staffing and patient safety, and or just go to the well and tell people you are?
Yes, Madam Chair. I would like to address that just briefly, if you don't mind. First of all, I want to thank the committee. We've had 3 bills for nursing that are very important to us that you have graciously sent out of here and hopefully will become law. One was mandatory reporting, which is vitally important for the patient safety of our citizens. The other is continued competence, which ensures that our nurses maintain their competency. And finally, this last measure that Representative Williamson has brought to you to help bring efficiency to the board. The problem as it relates to funding is that as it stands right now, even as we are with 2 boards, and even once we do this last step of improving our processes, we're going to be woefully behind. Right now, if someone takes a complaint, and we take that complaint and it goes to investigations, comes back to the board, and then we send it to the Attorney General's office, it may be 18 to 24 months before we can take action on a licensee who's causing harm to patients. And that's absolutely unacceptable. And that is 100% completely resource driven. Now, as the board chair, I thought to myself, well, if I need more resources, I simply need to raise my fees, because the law clearly states in 43-1-7 that I set my own fees, and I set my fees based on my own actual costs. So we set our fees based on what we believed we needed to run the board properly. And last year we generated $4.1 million in fees. We received back $2 million. I don't know where that other $2 million went. It goes to the general fund. All I know is that currently, because I can't raise my fees because I'm already overstated, I can't solve my own problems. And as a result, this is a measure that we're trying to streamline the processes as much as possible. And I would ask that you guys understand that the Board of Nursing is in a predicament. The legislative intent of 43-1-7 is clear. All the professions should regulate, the cost of their regulation should be borne on the shoulders of that profession. They should pay the full fee with no negative or positive financial effect on the state. Well, clearly that's not what's happening. $22 million last year came in through the Professional License Board. And the Professional License Board got back $10 million. So there's $12 million going to somewhere out there. And I understand it's tough financial times, but I'm supposed to be able to fund and be self-sufficient. That's my task. That's my statutory obligation. And I want to raise my fees. And I can't do it because I'm statutorily precluded from doing so, because my direct and indirect expenses are already lower than what I'm bringing in. So my real obligation as it stands right now is that I'm going to have to cut my fees or be in violation of the law as a board. And that is abysmal, because given the situation that we have right now and the added cost of mandatory reporting and continued competency, which we know and we've discussed in here, it is going to be impossible for us to protect the citizens of Georgia without adequate funding. And whatever we can do, whether that be becoming a budget unit, whatever that requires. In 1977, the Real Estate Board sued the state of Georgia and won on this exact same issue. As a result, they are now a budget unit and they get their money. Certainly real estate is important, but when your family member is lying in the ICU and you want to make sure that they're safe, and we can't administer that, the regulation of that profession properly, I would think that it would be important for us to get the funds that we want to generate as well. Because we're not asking for any funding from the state. We're asking to be self-sufficient as we've always been required to do. And that's really all I have, Madam Chair. Thank you.
Thank you, Mr. Cranfield. Are there any questions for the Speaker? Representative Kidd.
Thank you, Madam Chairman. I'm very much in support of the bill. But when you look at your budget aspect like you just did, do you factor in the heat, the utilities, and the space that you use, and
Absolutely.
the personnel you use, amount for guards, a certain amount that goes to the governor's office, et cetera, et cetera?
Absolutely. So the spreadsheet that I received from the Secretary of State's office, I'm sorry, there's feedback here. The spreadsheet that I received from the Secretary of State's office when I requested that I wanted to raise my fees outlined very specifically for each board, both the direct and indirect cost of the board's legal expenses, overhead, allocations, all of those things.
Could you share that with me sometime?
Yes, sir, I'll be glad to.
Thank you.
Absolutely.
Thank you, Madam Chair.
Let me, we don't have any other questions? You got a question? Okay, I did have a question, though. You're telling me it takes 18 to 24 months when you get a complaint, when you finally get a complaint, which is a voluntary basis, before the board can take disciplinary action. And during that time, does the nurse continue to practice wherever they want to without any interference from the board?
Unfortunately, Madam Chair, that is absolutely correct.
Ms. Phillips, Ms. Martha, could I ask you something, please? I don't mean to put you on the, could Martha stand up just a minute. Martha Phillips is the executive director for the dental board. How long does it take for you to discipline dentists that are reported and have a problem? So you have the same problem, and you now have a bill moving through to change that. Thank you very much. Thank you. I'm sorry to put you on the spot, Ms. Phillips. I needed to know it. Thank you very much.
Yes, ma'am.
Okay. Oh, I'm sorry, Representative Randall. I'm sorry. Your light's not. Is it on? Okay. Try speaking in your.
Yeah, it sounds like it's pretty high. I just have a question on lines, page 2, line 41. It's some real specifics that have been stricken, and I was just kind of wondering why, because it's real specific about the level of education that of each member, and then it's quite different with the new language. And I was just.
Are you asking the author or Mr. Cleghorn?
The author.
The author.
Thank you, Representative Randall, for that question. But this came as negotiated language between the two respective boards. I was not in that discussion. It seemed reasonable the way they had it broken down, because obviously back in lines 34 through 40, these are all people that are licensed for their specialties to practice these various aspects of nursing care, and I assumed if it was good enough for the state of Georgia for them to be able to practice this, that sort of met their educational obligations. So, although I did.
That is looks kind of suspect. You go from saying that 2 members shall hold master's or doctoral degrees to 2 members registered nursing educators.
Yeah.
Can you address that, Representative Randall?
Mm-hmm.
Yes.
Thank you. Currently, excuse me, in order to be a registered nursing educator in the state, you have to have a minimum of a master's degree. So it's already covered in regulation. So it was not restated through this. So the competency level, the minimum education level for the board member requirement has not changed. It's just stated elsewhere in the regulations.
And if I may, the APRN requirement, which is new, also requires a master's degree. In fact, we've actually made the education requirements more stringent than they were previous.
One other question, if I may.
Yes, go ahead.
The other part that I thought was interesting is apparently there was a need for to say that these members should, not more than one member should be from one private nursing school or from one school, and that's been changed as well.
That, what line are you referring to, ma'am?
No 2 members of a board shall be
Okay,
employed
I'm
by the
sorry.
same. 44, 45.
Yes, ma'am. That
46.
language was included in the existing
Right.
LPN statute, but it was not in the current RN board statute, and so it was not brought over. But again, it was in one statute, but not the other.
And you don't know why. I mean, because it's pretty specific, and I'm thinking people just don't come up with specifics like that unless there is a reason.
Yes, ma'am. Obviously, I wasn't there when the original statute was authored for the practical nursing program.
Maybe stacking the board from one school, maybe.
Perhaps that. Yes, ma'am. Again, again, I have no idea what the legislative intent was initially, because it was not in the existing RN board statute. We did not keep that.
Thank you. Representative Harden.
Thank you, Madam Chair. In regards to the ability to remove maybe a violator of public safety, if you will, does the board have the authority to issue an emergency suspension in the case where public safety is at stake?
Yes, sir, we do. And in those cases, we have to, it has to meet a standard that our Attorney General has set quite high in order to do so. It can't be suspicion. It can't be an investigation that has any leeway whatsoever. It has to be absolute, irrefutable proof in order to do that. And in those cases, it's normally a month or so before we can get them off. But the vast majority of our cases where we have to go through the entire process, the due process, which is appropriate, but it's too long because due process shouldn't take 18 to 24 months in these scenarios.
Okay, thank you very much.
Yes, sir.
Thank you. Having no further questions, Representative Watson, did you? Just a second. Representative Clark, did you have a question?
Madam Chair, I have a quick question. How will this shorten that process? Did you cover that? By combining?
No, sir, I have not, and here's why. The truth of the matter is the Board of Nursing, through Executive Director Cleghorn's leadership, has done all that we can, given the very, very, very limited funding that we have, to streamline our processes. We've received accolades not only from the Secretary of State but from our professional association in how we've completely improved, because it was 36 months. Okay, so it's far better now than it was before. Now, this is going to change very little, that 18 to 24 months, because it's still a resource-driven issue. But every small step that we can take in terms of best practices and increasing efficiency and realizing economies of scale, I want to do, because it's inappropriate for me to come to you and say, I need my funding that I'm due by law, unless I'm showing you that I'm doing absolutely everything I can do from a business perspective to streamline that process and be efficient. And this is the last step of that we see.
Representative Watson.
I'd like to make a motion that we do pass.
Do I have a motion to do pass? Do I have a second? Second. We have a second. Any further discussion? Then everyone in favor of the substitute to House Bill 332, that would be LC 2171S, say aye. Anyone opposed, no. Well, the ayes have it. Thank you very much. And thank you, Mr. Cleghorn, for coming up from Macon. And for Mr. Cranfield, one of the reasons that I let Mr. Cranfield speak on the issues was I wanted the committee to understand that it's not against the Secretary of State, but the budget cuts are impeding investigations and quick resolution of items that are important to the patients of Georgia, and to show how difficult that is in our tight economic times. Thank you very much. House Bills 461. Representative Rogers. And you can sit down if you'd like to. What do you want to do?
Okay, Madam Chair, members of the committee, I bring today House Bill 461 concerning how the state contracts for dental services and Medicaid and Peach Care are done. I want to start with a historical note. Madam Chair, as you will recall, this legislation passed this committee in 2010, as well as the full House by a vote of 157 to 4, and the Senate by a vote of 47 to 1. It was vetoed by Governor Perdue, who did not want to make any changes in case management organizations. I was prepared to reintroduce the bill 2 years ago when Governor Dill took office, but he asked that we not do it until a Medicaid redesign effort could be made. When that effort was paused this past year, we asked if we could have permission to again bring the legislation to the General Assembly for discussion. This bill does something simple. It applies the wisdom of the private sector by letting the state run its own contracting process to provide dental coverage to children in Medicaid and peach care. Right now, the state hires CMOs to provide both medical and dental coverage. However, the CMOs are medical insurance companies, not dental insurance companies. They are HMOs operating under a different name within the Medicaid world. Just like any other HMO, they do not provide dental insurance. And as such much subcontract, let me re-emphasize that, subcontract with dental insurance companies to handle the dental benefit required by the state Medicaid contract. However, like any middleman, CMOs keep a portion of the fee before passing it on to the dental insurance company they actually provides to the benefit. In fact, as we discussed, the fee kept by the CMOs has been substantially over the years running into tens of millions of dollars. Under this bill, the state would remove the middleman and run its own contracting process for the dental benefit in Medicaid and peach care. This bill requires the process to be competitive bid and puts the dental insurance companies fully at risk, just like we require the case management organizations. The CMOs themselves could compete for the business as long as they virtually provide a dental benefit and do not subcontract it out. I want to make an important point. These case management organizations are doing nothing wrong. They're doing what the contract put in place by Governor Perdue allows them to do. Get a fee for a dental coverage, subcontract the dental benefit to another company, and keep a large portion of the fee for running this contract process on our behalf. It is what any company in a similar contract would do. The problem is with the plan design. Georgia Medicaid is trying to do what almost no one in the private sector does, which is put medical insurance and dental insurance into one bundle. Medical insurance and dental insurance are different. They're not apples and oranges, and they're more like sweet peas and cantaloupes. By forcing medical and dental insurance into one contract, the way Georgia currently does, we are creating a structurally inefficiency that costs the state millions of dollars. The FY 2009 figures indicate it costs the state as much as $80 million to force medical and dental into the same contract. In fact, payment figures from FY 09 indicated the CMOs were keeping as much as half of the money they received for the state to provide dental services before they ever sent it along to the dental network. In effect, that was the fee for the CMOs charged the state for running the dental contracting process on behalf of the state. In the state, if the state were to contract directly for dental instead of using CMOs as a middleman, Georgia could save, as I've said, tens of millions of dollars that could be used to help balance the state budget and help dental providers actually serving children. This is what states around the region and country are doing. South Carolina and Mississippi did it the same year we tried to in Georgia. Louisiana is doing it this year under the leadership of their governor, who has been a leading voice in applying good business sense to Medicaid and health care. Several more have done it elsewhere. If we want to apply the wisdom of the private sector to government, Georgia should be the next state to direct contracting for dental services. To prove my point as clearly as possible, the Department of Community Health itself handles medical and dental insurance directly and separately for the state health benefit plan. We believe that the state should follow the example of the private sector and the example of the Department of Community Health on the state health benefit plan and do the same direct contracting for dental within Medicaid and Peach Care. To be clear, Governor Deal told us he has taken no position on this legislation, and DCH, the Department of Community Health, is here speaking for itself and not for the administration. We accept the Department of Community Health's efforts in good faith and will continue to work with them to resolve any concerns they have. However, there must be change in the program if we're going to make it as efficient as possible and free up resources to allow dentists to actually serve children rather than have that money absorbed by CMOs. We can't wait 2 more years before we do so. The state budget, as we all know, is too tight, and the providers are too strapped to do that. With that, I want to introduce Andy Orris, head of the External Affairs of Cool Smiles, the largest. Okay, Andy's not here. Anyway, just to put it as a whole, we have done this legislation 2 other times with 2 vetoes, and I just want to mention again, the administration has not taken a position on it. We do have their ear, and I think if this committee sees favor to do so, Madam Chairperson, we might be able to. I did. I can't hear you. I don't know if your mic's on or not.
Mic's not on. Thank you. Okay, if everybody would get it. If you look at the second page, this is a Medicaid card. This is how the system used to work for dentists. If a patient had a Medicaid card, they went to the dentist, they got the services that were allowed, and then the state paid them. If you turn over to the front sheet, if you look at the second part, what's happening now, in the dental community, they've had 6 changes in the last 3 years of who oversees it. They've gone from ACS to EDS to ACS to EDS to HP. Now, this is asking providers across our state, rural dentists, who usually have 1 front person and maybe 1 person helping them in the back, not like in Metro Atlanta where you go in and there's a dentist and 3 hygienists and so forth, that are seeing our Medicaid patients. And if you look below, it sort of shows you what happens. DCH runs the aged, blind, and disabled area, so they have 1 set of rules and 1 way to reach them. And then you've got the 3 CMOs who contract out to these people that run the dental part. Then there's the Peach Care program, the Pregnant Women program, the adult program. They all have different computer places where you go, websites where you have to go to get the information. Some of them require separate patient numbers. They have different copays. They'll pay for different things, different guidelines. I would like for everybody to think about it. If you were an independent provider trying to deal with this and stay in business, we are begging people, dentists, to see our children on Medicaid. And if you ever wonder why physicians and dentists don't want to sign up to the program, I think this chart tells you why they don't want to do it. Because it's so involved, so time-consuming, and they also have a problem to get paid. I have 1 dentist that has 100 patients he hadn't been paid for. He now has been, and they were from October. Now this last month he's gotten paid for 50 of them. I mean, a small dentist in a small town can't operate with that kind of a problem with his cash flow. I mean, do you see anything wrong with this, Representative Rogers?
I do.
I mean, is this what people are telling you across the state, the dentists that are trying to see our Medicaid patients? We just have a major problem in this area. And for new members and people who have not delved into it, or your dentist haven't called you because you live in the metro area and it's not quite the same problem, I just want you to know what they are up against. And while I'm at it, I want you to know that we are only, and this is, they'll pay for different, well, first of all, Dental Quest, I think it's Dental Quest on that list. We don't have enough people to see our Medicaid patients. And I think there was over 100 dentists that wanted to be on the program, and they told them the panel was closed. You know, it seems like to me that it's a way of not paying out the money that the state has given you. If there's nobody to see the patients, and you've gotten so much for dental care for each patient, but there's nobody to see them, you get to pocket that money. Is that correct?
That's correct.
And that one way to keep a control of that is how many people you'll let into your program. So, but the other thing, while we're at it, I want to say, I find it deplorable. We are the only state in the country that will not allow our children on Medicaid programs to have a root canal on a permanent tooth that comes in. And if you take out that tooth, all that's they will allow the dentist to do on these children is remove the tooth. If it's rotten and infected, they will allow them to treat the infection, and then they will allow them to remove the tooth. If you remove a permanent tooth on a child that's 6, 7, 8, what happens to their mouth? As the new teeth come in, it begins to shift. You are giving them dental problems for the rest of their lives and causing problems with the way they can eat and function. To be the only state out of 50 that does not allow this is deplorable. And, you know, I really think it needs to be corrected, and I think it's going to take legislative pressure on the people that run our Medicaid program to really explain why 1 out of 50 states, why that is so difficult for this state to pay for. And maybe if we had this one provider and saved the $88 million, maybe we could add that back in so the children of this state could, you know, not have their permanent teeth removed and have dental problems for the rest of their life. You can tell I'm sort of with you, Representative Cindy Rogers, on this issue.
Well, and let me say the Georgia Dental Association supports this bill naturally, and as far as I know, the CMOs are the only ones opposed to it, and naturally. I mean, again, nothing against the CMOs, but they were hired to do a job on an RFQ, RFP, and here we are, and we tried to fix it, and we will continue to try to fix it.
Okay, you have a couple other questions. Representative Kidd?
Yes, ma'am. Thank you, Madam Chair. Sounds like, I know you're a nurse. It sounds like you were a dental nurse rather than another type of
No,
nurse.
I really hate going to the dentist, and so I'm just trying to keep those kids from having to go to the dentist
Great.
later in life.
Thank you, Madam Chairman. I was asked to ask you this question. Is that this bill doesn't require a fiscal note, does it?
We don't think so. It didn't the last 2 times, Representative Kidd. All we're asking them to do is pull it off and RFQ and RFP it.
I agree. And at proper time, Madam Chairman, I'd like to make a motion.
Well, this is not the proper time, but Representative Kidd, I don't think that we give fiscal notes that say the state's going to save $88 million when they take out the middleman. They're usually on the negative side. I've never seen a fiscal note that says we're going to make a lot of money if we pass a law. Representative Shepherd.
Thank you, Madam Chair. This may be a question for the Dental Association, but looking at this whole process, I'm wondering the positive impact that it's going to take, just say in Georgia. How many doctors are saying, hey, look, if y'all can correct this, we're on board, and how many kids would that allow them to see? Do you have those numbers at all? Or an idea?
Martha, you can come over to the podium so everybody can hear you, please.
I'm Martha Phillips. I'm the Executive Director for the Georgia Dental Association, and I thank you for that question. We recently did a workforce census, and we had 104 dentists who said that they would like to participate in the Medicaid program, but they are not allowed to. DentaQuest has a closed panel now. We have 3 CMOs and 3 different subcontractors for dental. DentaQuest was the subcontractor for WellCare, which is the largest CMO provider. They've just switched over now, and I think it's Avisus that will be their subcontractor.
Okay.
So, yes, we know of at least 104 dentists.
Okay, and do you know how many kids that will
Oh, my gosh.
Thousands?
Thousands,
Okay.
thousands, absolutely. And, even though in the past, in 2011, we had 12 dentists who either shuttered their doors or they went bankrupt, and they were primarily Medicaid providers. And part of the problem is the fact that, and this further exacerbates the problem of the kids being seen, the problem is that since the inception of the CMOs, the dental fees have been cut. We were cut from the very beginning, and we've continued to be cut. Our fees are at least 15% to 25% less than the age blind and disabled fees for dental. DentaQuest, or actually, I'm sorry, it's WellCare now, they cut their fees by codes, and some of the fees have been cut 20 to 59%. So even with the fees the way they are, we're having dentists who can't make it because of the fact we've got a duplication of cost. For every CMO that has to subcontract, there's a duplication of that CMO's administrative cost and their profit, and the same thing for the subcontractor.
Okay, so thank you
It's
so
just
much.
extra cost in there that could be used to provide more care to the patients. And quite honestly, it's very difficult for dentists who are primarily solo practitioners with very small office staffs to be able to handle the changes that they've had to handle since the inception of this program. WellCare has just changed their subcontractor. We're not crying about it, but it's a change. I mean, Avisus was in, then they're back in. DentaQuest used to be WellCare, now they're only, I think, Peach State. I'm not sure. I can't keep up with it. It just changes so frequently. So we are faced with changes on a constant basis.
Okay, thank you so much. I guess we got a new CMO means cut middle out. All right.
Very good.
All right.
Very good.
That's a good one.
Yeah.
Thank you. Representative Beverly.
Thank you, Madam Chair. The line 25, 26, the single administrator shall establish a dental provider fee which is at least 85% of the maximum allowable. Why would you go to 85%? Because the fees are already low. If I understand, I mean, dentistry and optometry bill in a very similar fashion. So just for instance, if you have $100 in a CMO, and you're going to do 85%, they're already low fees. Why would you cut them even lower? I'm not sure I understand.
Considering on a lot of fees we're getting 30 and 40%, that's a huge increase for
So it'll
us.
go up, because you guys are 30%, you're going to go to 85. Okay.
On some fees, on some codes. Again, some of them have been cut 15 to 25%, some codes as much as 59%. So, we're realistic. We recognize what the economy is, but we believe there's enough savings if you have one single administrator. It's been proven there are at least 7 or 8 other states that have single administrators, and it works there. And we believe there would be enough savings that you would be able to pay these fees. And again, remember, this would be competitively bid. The state would not be at risk. Any entity that bids understands what the contract requires at the time that they bid.
Okay. Just a quick follow-up. So this benchmark, this 85% is benchmarked against what currently is or what was?
The fee-for-service fees, I
Fee-for-
believe. Isn't that what we based them on, Clint? Or the 100%, the 85 of the fee-for-service fees, is that what we based it on?
Okay.
The current fee-for-service fees that are paid under the age blind and disabled,
Gotcha.
which is
Okay.
what's being paid now.
Gotcha.
Okay. Other questions? Oh, no. Okay. Thank you. We have other people who want to speak on the bill. Representative Rogers. I will tell I think anybody on the committee that's had a toothache knows how uncomfortable that is, but I was shocked a few years ago when the head of Grady Hospital came over and told me and asked the committee what the #1 reason for people going to the emergency room at Grady was not Rex, was not heart attacks, it was tooth pain. And so, I mean, when your mouth hurts, when your teeth hurt, you're in trouble and you consider it an emergency. And yet we have such poor dental care for our Medicaid patients. Jesse Weatherton?
Afternoon, Madam Chair, members of the committee. Thank you very much. I'm Jesse Wellington. I'm the Legislative Director for the Georgia Department of Community Health. We're here today to go on record as being opposed to House Bill 461 for a couple of reasons. Mainly, we believe that there would be a potential deleterious impact to the quality of care received by our Medicaid members who are currently served by integrated medical and dental service CMOs. I do believe that there would be a significant fiscal impact to the state because of this. We're talking about potentially millions of dollars in savings and then a fee schedule for rate increases, and to me that suggests a definite fiscal impact. And there are also some negative administrative issues that would be created for the department, maybe less significant than the first two issues, but significant to us. As such, I would like to ask Dr. Jerry Deverly, who's the chief of the Medicaid division, to come and elaborate on some of the department's concerns.
Thank you, Madam Chair, members of the committee. I appreciate the opportunity to speak to you today about our concerns. With this bill, I want to start by speaking to our commitment to dental and physical health. There's a close correlation between the two. And the U.S. Surgeon General's report on dental health points this out, calling oral health an inseparable part of general health and well-being. This message has been reiterated by the American Academy of Pediatric Dentistry. And the Surgeon General goes on to talk about the integral relationship between oral and general health, including the association between chronic oral infections and diabetes, osteoporosis, heart, lung conditions, and adverse pregnancy outcomes. So clearly there is an association between physical and dental health. As you know, in our current environment, most of the dental care for children in our CHIP program and Medicaid program is provided through the care management organizations. These organizations are at full financial risk and contractual accountability for outcomes. If a member is not able to access appropriate dental care, as mentioned, they typically will present to the emergency room. There are very few things that are as painful as dental pain. If that individual presents at the emergency room, the CMO has to pay for that emergency visit. There's a built-in financial incentive for the CMOs to provide appropriate access to appropriate care to avoid having to pay for these more expensive procedures. Additionally, with establishing the relationship between poor oral health and physical health, they're also at risk for those other disease states we mentioned that could be developed. So if we move forward with this bill, this would carve out the dental portion from the physical portion and separate those two. With doing that, we have to revisit the fact that now we've taken a very valuable tool away from the CMOs for managing the entire health care of the individual, placed them at higher risk of paying for emergency room visits and other chronic conditions. So with this, we believe that there will be a fiscal impact to the department. In fact, the last time a similar bill was presented, there was a review by the Department of Audits and Accounts that projected that this would be as much as $49.2 million per year in increased state funds to the department. So we respectfully ask that any movement of this bill would have a corresponding fiscal note. Finally, I wanted to point out just some of the successes that we have had with the dental program. Over a 3-year period, the CMOs have moved the Medicaid managed care population into the 90th percentile for dental access in the country. This is a huge accomplishment. 82% of the increase, we've seen an 82% increase in dental visits and dental access for children 2 to 3 years of age. In all the other categories, we've not seen anything less than a 28% increase. So while there's still improvement to be had, we are clearly improving under the current model. We don't want to separate physical and oral health. And I just want to stress the fact that if we do move forward, we would ask for a fiscal note.
Mr. Deverly, when you say that we've increased access, what do you base that on? The number, is it not based on the CMOs telling you they have so many dentists in each area?
No, ma'am. This is based upon independently validated data that looks at the number of dental visits. So the increase in actual dental visits or encounters that the members have had.
Okay, that brings me to another issue that I want to ask you about. You know, we have a law in the books, and one of the ways that that may be increasing will be these mobile dental buses that are allowed to go out. There's a law in the books, and I want you to tell me where that law was changed. It says those buses cannot go out more than 100 miles from their original office, which I think the one that goes out is in Duluth. Yet they are going all out across Georgia. And they're supposed, and the idea when that was established that buses where they would go to, underserved areas in that 100-mile radius. And yet what we're finding is the buses typically go to a place where there's already a dentist. And they find a way to get the school nurse to let them, suggest that they come into the schools and that they see children from the school and they see all of the children. They don't decide whether this child has a dental home or whether it's a child that doesn't get any care. So, and when they do the care, and you talk about this coordination between other diseases and back and forth, and I would include dentists if you want to communicate that, is that they do the x-rays, and I'd like to know, and I'd like to see one of these buses and know when dentists have to have their walls of their offices lined with lead. I'd like to see one of these buses and see how they get away from that. Maybe there's some kind of new dental x-ray machine for children that doesn't put out enough that hurts children, but in that bus they'll be doing x-rays and they'll have maybe 2 or 3 places for a dental hygienist to clean teeth. And not only will they be working on the children, they'll have 5 or 6 or 7 lined up in the bus also being exposed to whatever's going on. And children who are watching other children that don't like the dentist, like I was, having treatments to self. And so what they're finding when we're having dentists across our state go out of business is that they are doing the x-rays and they are doing the cleanings, but if they find anything that's much more involved, then they send a note with the child that they need to see their dentist. But there are no records of the x-ray that go with them then or what's been done to them. So they're sent back to their dentist with a piece of paper saying, you need to see your dentist for further dental work. So there's no coordination between the two. And so first of all, what allows you to let a CMO break a state law and let those buses travel all over the state of Georgia?
In terms of the requirement, there has to be a brick and mortar relationship between that mobile dentistry. And so a mobile dentistry unit cannot go out and see children without having agreement with a local dentist who agrees for any follow-up care. So that's something that we felt very strongly about and we memorialized in policy as well.
And you're saying that just because a dentist in the area will say that they will take care of these children after hours once they're gone. I mean, could that be the reason that they go into the town that has a dentist and they don't go to our counties that have no dentist, that because they want to be able to do that? And is that really a brick and mortar? Just agreeing to have an emergency situation with them lets you get past that law of saying where they can go 100 miles?
We believe we're compliant with the law. Yes,
I'll ask the Attorney General's office for a ruling on that, because I think that is pushing the letter of the law. And I think that you are putting dentists who invest in our communities around the state at risk for staying in practice, and that these buses are not going into counties that have no dentist where they can't make that agreement, and those children who need dental care more than anybody else are going without it. And we are giving free dental care or Medicaid care to children that already had a dental home. I don't see how that coordinates things, and I think that's a problem. Yeah, so, but I will be asking the Attorney General for a ruling on that 100-mile rule, because I think that is another way that we're having a problem.
Thank you.
Representative Harden.
Chair, I'm just trying to do a few numbers here based on your statements that you just made. As I read this bill, it says that it would be 85% of the maximum allowable cost of payments for dental services as published by the department in Appendix B of the Policy and Procedures for Dental Services. Now, you estimated that by making this switch it would cost somewhere in the neighborhood of $49 million more then by looking at the 80-something million it is now, if it's going to go up 49 million, that means your cost is going to go up 61%. Now, if you take that and apply it to the 85% figure, it must mean that we're paying dentists 34% of maximum allowable cost at this point. Do you follow the math there?
I don't, because the $80 million is certainly not a department figure. We don't pay the CMOs a specific dollar amount for dental. So
well, that's the amount that we have heard testified here today, and that's why I was using that. But it does appear, regardless, a $49 million increase, even if it's $100 million now, would still mean that you're paying dentists in the neighborhood of a 34% of maximum allowable cost, or the CMOs are paying in the neighborhood of 34% of maximum allowable cost.
If I may clarify that dollar amount, that 49.2, is not a department generalized. That's the Department of Audits and Accounts who published that, so I'll kind of defer to them to justify that. But I think there are a couple of components to recognize that it's the administrative payments that we would have to pay the single statewide dental management organization. There's also the fact that now I have to pay the CMOs more because now they're at risk. Whenever that DMO or the dental management organization doesn't provide access or appropriate access or appropriate care, the CMO is now going to be on the hook for the emergency room visits, the chronic conditions that can develop, et cetera. So there's a part of that is the increase to the CMOs that would have to be corresponding.
Well, then, if I may, Madam Chair.
Yes, go ahead.
Then in that relationship, we've heard testimony, and I think it's probably true, that in general, medical insurance is separate from dental insurance. Now, if that is the case in a private sector where they're trying to manage cost very strictly, then why is it now a positive thing in this arena? I can't follow the reasoning, I guess is what I'm saying, and I would like, if you don't mind, for you to work through those figures I just threw out there from what you have available to you, because if we're paying dentists 34% of maximum allowable cost as published by the department, I think that's basically wrong. Right. And I would appreciate you trying to clarify that for me.
Will do.
So, Representative Hawkins.
So let me get this right, and I want you to help me understand this. It's going to cost the state less money to have more providers because they kick money back from the dental plan to the medical plan. So if we have one provider, that's going to cost us more money?
That's not my statement.
Okay. Would you state it again then, please?
Sure. If we take away the ability of the care management organization to manage the entire person and their entire health care, again, the American Dental Association says the mouth is a gateway to a person's overall health. If you put somebody at financial risk for the overall health, but you take away the gateway or you take away the most integral part of that relationship, then there's more risk shifted to the CMO because they're having to pay for the ER visits, et cetera, if it's done poorly. So that's what I'm saying.
Okay, so, but I heard Representative Rogers say we give money to, say, WellCare, and they turn around and pay visas to do the work for them.
Correct.
Is that correct? So it's not going to save us money if we had someone else doing it and just paid them directly and save the money that goes to WellCare. You're saying that we'll have to pay more to WellCare for their medical.
Right.
So that's what you're saying.
In addition, you lose the coordination between the dental and the medical because now it's in two separate places. Today, WellCare is on the hook for the dental performance of their sub. So they are held contractually accountable for the dental outcomes. Right. I lose that ability to hold them accountable.
So how does it work in other states so well?
Well, as you know, they're only it's about half and half. 25 of the states carve it out, about 25 don't. So I would say that it's working very well here. For Georgia to be in the 90th percentile for dental access for Medicaid, that is a huge improvement.
Well, that is an amazing number. I just don't hear those numbers coming back from dentists.
Right. And Mr. Dudley, maybe you shouldn't come before a committee that has a nurse and a dentist and a doctor on it. But you were talking about how that, we have to let them do this because they'll lose coordination between diabetes and all the other illnesses. You know, those are illnesses mainly of adults. And is it not true the main people that we treat with our dental program are children?
It's true that it's mainly children, but as a nurse and as a pharmacist, I recognize that if you get an infection, you can very easily have that go to your heart. You can lose a kidney. So there are a lot of application of
right,
these
but it is
well.
very seldom. I'll have to correct you. That would be something that would rise to that level. So for you to say that that is a major reason for saying the two should stay together, I think is a major fallacy. If we were paying for dental care for our adult Medicaid patients, that might be a true argument. But when we are mainly covering just children in this state, that is an invalid article.
I appreciate your opinion.
Okay, Representative Rogers.
Mr. Dubey, I want to ask you this question. Do you work on the state health benefit plan as well?
I do not.
You do not? Do you have any idea what we pay, the state of Georgia pays for consultants for the state health benefit plan?
I do not.
You don't have a clue?
I do not.
Try $100 million. Think that's enough?
I have no opinion on that.
You do not? Okay. Thank you.
You know, I tell you, I've seen the linkage of oral health care and you know, systemic illness a lot of times, but golly, I tell you, that was sort of stretching a little bit. I'm not sure I have a question. I did earlier, but you know, if there are no other questions, well, I think I do see another question, but we at the appropriate time.
Representative Rogers. Do you have Rogers? Oh, okay. We got another one. Okay. All right. Thank you very much. Let me tell, we're pretty unhappy with the reports we're getting. That. You may be over in, you know, number 2 or wherever it is, and maybe they're just going to get up to you. But we're the ones that hear about the problems that are out there, and they are not good. And so you can sit in your ivory tower over there and think you're doing a great job, but let me tell you, you're not. And if I remember correctly, you're the one that made the decision that we should have epileptics fail twice on medications before we give them the brand necessary if needed. That was a really smart decision, and I think that, you know, I just question some of this ability to run the program and make decisions like not letting children have root canals so their mouths will be messed up for the rest of their lives. Thank you.
Thank you, Madam Chair.
Dr. Brody, if you'll come forward and tell us who you're with and your position.
I just want to say I love you.
Thank you, Madam Chairwoman. I appreciate the opportunity to address the committee. I'm Dr. Mindy Broda. I am the State Dental Director for Avisus, who is subcontracted with WellCare as of July. I'll give you a little bit of my background to start with. I received my DMD degree from the University of Alabama School of Dentistry. I've also completed a master's in public health and a dental public health residency at both UAB and the dental school there. Completed those in 1994, graduated from dental school in 1987. I was licensed in Georgia in 1994 when I came over here to accept the position as director of Fulton County Health Department's dental clinics. From there, I helped them start their Medicaid billing to supplement their county budget. After that, I became director of Cobb and Douglas County Dental Clinics. I was dental director for Delta Dental Insurance Company and has served as state dental director for 2 of the dental CMOs in the state. I spent over 15 years in clinical dentistry, both in the private and public sectors. I was with Avisus from 2006 to 2009 as their state dental director and have come back in that position. Avisus is the dental administrator for WellCare of Georgia. In the past, we've been the administrator for Peach State Health Plan from 2006 to 2009. Avisus recommends a single dental administrator due to the impact that it would have on the Medicaid members and the difficulties in coordinated activities between the medical and dental administrators on behalf of those members. Avisus believes the current relationship between the dental CMOs and the dental administrators has been a positive one for the Medicaid members. The relationship between the medical and dental administration has allowed the dental administrators to create effective initiatives for improved dental health in concert with medical CMO members' relationships. There have been several initiatives in which dental programs have helped decrease the medical costs, such as the introduction of IV sedation centers. Avisus believes that in today's world, a medical home for members can only be fully achieved with the partnership of the medical side and dental side, excuse me. Up to 90% of systemic illnesses can first be identified in the oral cavity. Even pregnancy can be identified early in the oral cavity. Without a medical partner to ensure access, many diseases would be left untreated or treatment started at a much later time. It is the dental CMO that provides the medical CMOs with not only the periodicity of treatment for patients, but works to ensure pediatricians are aware of things such as the necessity of early visits and the use of fluoride varnish. The dental CMO provides the medical CMOs with the appropriate materials for members. It has been shown that when members are provided this educational material through medical CMO, that dental visits increase. In Georgia, WellCare has had a plan rate of 70.46% utilization in dental visits. This is above the national dental benchmark of 64.48%. And WellCare and Avisus are in the process now of developing even more educational material to be distributed to members. The separation of dental from medical would create confusion among the members. If the relationship were to be severed due to the carve-out, the member would be the one to suffer. There would be confusion as to the information sent to the members, as they would now be receiving the same information from different sources. This would be a more splintered approach to healthcare, as the ability to work together would disappear. Dental CMOs do not have the resources of medical CMOs to provide the interface with members that is required. Outreach would cease and thus result in a drop in both HEDIS scores and EPSDT tracking. Dental CMOs cannot employ the social workers and the educators that are required to achieve these outreach methods. Lastly, a dental CMO would not have access to or the ability to acquire the medical history of the member to ensure they are receiving the proper educational and preventative materials.
Thank you, Dr. Bodie. Are you insinuating that the parents of most of our patients on Medicaid and getting dental do not have the mental capacity to tell the difference when they are getting two different pieces of paper from a different provider, and that they're going to be confused if they have one provider and one information coming from on dental thing and one on medicine?
Not at all. I would not insinuate that at all. I did not mean to.
That's what you said.
I said that they could be confused because there might be differences in the way that the information from the medical CMO is worded and the dental CMO on the same information.
Okay, questions for Dr. Bodie? Okay, thank you. Representative Rogers, do you have anything else you'd like to add?
I would like to move to a question.
I have had Representative Wilkinson ask me to do that. Will you allow him to do it, please? Representative Wilkinson.
Thank you, Madam Chair. After counting to 10 more times than you can imagine and taking many deep breaths, I now realize why Dr. Bobby Kaufman keeps me on blood pressure meds. Madam Chair, I move do pass House Bill 461, LC 335089.
Okay, I have a move to do pass, and I have lots of seconds. Is there any further discussion? You're funny. Okay, so we have a motion and a second, no further discussion on the passage of House Bill 461. That's LC 335089. Everybody in favor say aye. Aye. Anyone opposed? No. I think the ayes have it. Thank you very much. And I hope that everybody got the message, no matter what happens going forward, that we feel like the children of this state are not getting dental care, that our dentists in rural areas are being put out of business because of the practices, and that we are extremely concerned and irritated about it, and we want to see a difference. Thank you very much. All right. What have we got left? Right. Okay, 240. Huh? Okay, Representative Carson, you think you want to come forward now after that? I may have helped you pass your bill. So this is, Representative Carson has House Bill 240 for us to present to us. That is LC 4975.
Thank you, Madam Chairman. I got to say, just first off, before we talk about 240, I've never been in a health committee meeting, but I'm never going to bring a dental bill here, I can tell you that. I have with me today, just for additional color into what we're talking about, Kelly Ball. She's the president of the Georgia Speech Language Hearing Association. What we're talking about here in House Bill 240 is basically the ability of what is known as a clinical fellow to be able to bill for Medicaid reimbursement in the same form and fashion and abilities as a speech-language pathologist. What is a clinical fellow? So we're talking about speech pathology here. A clinical fellow is someone who has passed their undergraduate degree, their graduate degree, they've passed their practice exam, they've completed 400 hours of supervised therapy, they are licensed with the Georgia Provisional License, and they're currently working under the supervision of a speech-language pathologist. The only thing they're needing to become a full speech-language pathologist is 9 months of residency under the direction of a SLP, speech-language pathologist, in order to receive their accreditation, their licensing. What this legislation does, it allows the clinical fellows, again, they're in the process of completing their 9 months of quote-unquote residency. It allows clinical fellows to receive medical reimbursement just as a speech-language pathologist, an SLP, specifically for outpatient hospital therapy and private speech therapy. The private speech therapy, which would be covered under Children's Intervention Services. CFs right now, as is being practiced in the state of Georgia, can be Medicaid providers for both inpatient hospital therapy and therapy in public schools, which is covered under Children's Intervention School Services. So we're talking about SLP. SLP can bill for Medicaid reimbursement for public schools, inpatient therapy, outpatient therapy, and private speech therapy. The clinical fellows can only bill for Medicaid reimbursement for therapy in public schools and inpatient hospital, not for outpatient or private speech therapy. What we think this would do is allow more flexibility for Georgia speech language companies in order to hire and retain the best talent, and I'll tell you why. If you have a professional services firm for speech pathology services, and you're hiring 5, 10, 30 people to go out and do various speech services for children who are on Medicaid or what have you, if they're trying to provide those services, not in a public school, not in an inpatient, but rather in a private speech therapy, like in a private firm doing these therapy sessions in regard to speech, as well as outpatient basis, you have to, as an employer, you have to send out an SLP to do that. Otherwise, you're not going to get rid of Medicaid reimbursed. So what is happening is that the other states around us that do allow this, and by the way, 39 states allow the Medicaid reimbursement in the format, in the fashion that we're asking Georgia to do, including our neighboring states of Alabama, Florida, and the Carolinas. So if you're a clinical fellow and you've completed your undergraduate and graduate degrees, maybe at Georgia State or somewhere, and you've passed your exam, you've done your 400 hours, you've got a provisional license or what have you, you might very well say, you know what, I have more job opportunities in Alabama or the Carolinas because the firm that I'm going to has more flexibility to bill for Medicaid. As I said, surrounding states allow clinical fellows to bill for Medicaid reimbursement in those scenarios. And I mentioned 39 states total currently, is that correct, 39? Allow for the medical reimbursement under those 4 categories that we're asking clinical fellows be available to. I wanted to bring up in regard to cost. By the way, Madam Chairman, was the fiscal note distributed with this as well to the committee?
I'm not sure that they put it, did they put it out? Okay.
Okay. I want to point out a couple things on the fiscal note. I don't believe this bill will increase costs. And the reason I believe that is because you're not increasing the number of children or Medicaid eligible recipients that would be receiving CF services. You're basically saying instead of this population under outpatient or private speech therapy, instead of them always having to be served by a speech language pathologist for Medicaid reimbursement, we're saying you can also or send out a clinical fellow. So we're not increasing the amount of services. We're getting more flexibility to the firms that staff these speech therapy services. And I would point out to a couple of items in the fiscal note. Do you have that in front of you? In the second paragraph on page 1, the first sentence says, an accurate estimate of the potential fiscal impact of this bill could not be readily determined as DCH did not have information to identify the extent to which underserved or unserved populations may currently exist. So we're not talking about additional patients here. We're talking about more flexibility for the providers. I just want to be very clear about that. Skipping down to the bottom of that first page, the last sentence, neither DCH nor the DOE had information regarding the extent to which there may be unserved or underserved school children with SLP needs. However, these agencies indicated that such populations may be minimal due to federally mandated IDEA programs. So basically, what we're saying is we don't know with very much granularity at all, if there are any, of people that are not being served. What we're talking about, and sorry to belabor the point, is more flexibility to provide those Medicaid services. This bill is being brought to us by the Georgia Speech Language Hearing Association. We have a letter of endorsement from the American Speech Language Hearing Association. Georgia Society of Hearing Professionals is behind this, and it has bipartisan support in our chamber.
Representative Carson, who's against the bill?
I can't think of anyone at this moment, unless someone signed up that I don't know about to talk about it.
I thought that the Department of DCH and Medicaid said that they would oppose the bill.
I have not heard that specifically.
Then they told me. And the person in charge of Medicaid would be the same person who just testified, Mr. Dudley, who helps make those decisions. Am I correct?
Presume so.
If the lady so speaks.
Yes.
My seat mail. So I think Mr. Wethington is outside the door. I think he's going to miss his chance to. But we have.
That's okay.
We have questions from the committee. Who've we got? Right. Who we got? Representative Reinders, are you on?
Thank you, Madam Chair.
Okay.
Madam Chair.
Right. I think. Did you want to testify on this bill?
No, ma'am. We do not have a position on this.
You have withdrawn it because you told me earlier you would be opposing it?
No, we were speaking about 461. I'm sorry if there was any confusion. We do not have any position on the speech pathologist bill.
Okay. Don't usually misunderstand what's said to me. Thank you very much. Okay. Who?
I didn't want to interfere.
Sorry, Representative Reinders.
Thank you, Representative Carson, for bringing this. And I'm always, especially in rural Georgia, interested in the expanding access because we have access issues. And this isn't really a statement per se about this particular bill, but a confusion. I constantly hear about Medicaid reimbursement rates. Just, it's just not enough. That's a theme I hear all the time. And yet I'm always confused on why people say, but I want some of it. That's a logical question. I mean, if it's not going to expand, if we're not cutting into the pie anymore, and if Medicaid is so poorly funded, then why would this group or any other group say, but cut me in on it?
I think it's more to what I was saying earlier about the flexibility for firms. If you want to go out and hire someone as they're coming out of school and they've taken their graduate degree and they pass their exam, if you're a small shop and you do a fair amount of Medicaid billing, and that
what would be a fair amount?
I don't know, 50%.
Okay.
Maybe we're talking rural Georgia here.
Okay.
Okay. But if you want to have that flexibility such that you don't have to structure your time to make sure you send a speech language pathologist because this client over here is in a private therapy session, or this client over here is on an outpatient of the hospital basis. If that's what your concerns are, then yes, this bill would matter to that person, because we're not talking about more kids that we think are underserved and so forth, and that's noted in the fiscal note. Again, this is about more flexibility, and I don't know what those rates are exactly. I think they're in around $60 to $70 per hour for these types of services. So we're not talking about that. We're really talking about the ability, the flexibility to provide those services.
If I may continue, Madam Chair, I co-sponsored a resolution with Chairwoman Sheldon on Medicaid reform, and that's kind of why I want to dig down just a hair. It isn't about this. It's about all the people that say Medicaid's never enough, but at the same time, we're not, our reimbursement is so bad, we're just going to drop Medicaid. Don't we all hear that? Mm-hmm. And then I sit there and I go, well, if the pie's so small, why do we keep trying to split it? And that's a little illogical to me, and I want you just to help me understand that.
Well, all I can say is
someone going to Tennessee on the jobs thing because they want more Medicaid patients?
You want to speak to that?
Yeah, hold on just a second.
Just help me understand the concept.
Let Dr. Hawkins, Representative Hawkins, answer the question.
You make a good point, Representative Reinders. The situation we see as providers is, yes, Medicaid doesn't pay us hardly to pay our own.
Carlson, did you say Rogers?
No, I said Reinders. You can't hear either. Yeah, but to answer your question, doing Medicaid is not about money. Doing Medicaid is trying to help a kid that's crying, that's in pain, and so you'll have dentists, trying to get into a system because they have those kids in their town. And as you heard earlier, we got CMOs that say we don't need you, but the kids have nowhere to go. So you're hearing two different stories. So these folks down here, they're just trying to help kids because kids need the help. That's what we're talking about as kids.
But the people that say, the reimbursement's so bad, I'm just going to drop out of the system?
Well, some do that, yeah. But you have some that are willing to do it. They're not making a lot of money doing Medicaid. This is about the kids, not the money.
Thank you. We always hear that, and I'm trying to find where that balance is. If it's so bad, why do you want some of it?
Well, I think, Chairman Reinders, with all due respect, because currently there's less flexibility in the system right now for a clinical fellow who has all the right training and is just going through their 9 months of residency, their Medicaid rate for those two types of services is 0. So would they rather take something more? That it may not be what a private insurance might pay, no. But would they seek to have that flexibility to provide those Medicaid services with qualified individuals? Yes.
Okay. Thank you.
But I do hear your point about the Medicaid.
And I'll try to explain it to you later, so put it in simple terms so you can understand it.
Thank you so much. Not that you're driving agenda on this committee, but didn't we just listen to the logic? Didn't we just take something where we had several different providers and go, no, we just want one? And now we're sitting there going, well, help me understand. Okay. Well, not providers. Right. Not providers. Wrong word. But anyway, thank you. I appreciate it. I'm just trying to understand that.
Thank you.
What can I add to that?
I mean, is the reimbursement rate enough for to survive or not? I mean, we
Well,
hear all the time people leaving the systems, but others say, give me a little bit more of the pie. That's a fair question of how do you find that balance?
Well, it is, and I think some of our states, some of the state also, you have to consider that in some parts of our state, it is largely, the people are largely Medicaid recipients. So that's, it's disproportionately, a larger amount of people to be served are the ones that are on Medicaid. Right. So it's and in that, then truly, as you hear about the dentists closing their doors because they can't survive. And I will say, Mr. Wethington, that I still think I heard, at least maybe I heard that you were thinking about not going against the bill, but also on the last page of the fiscal note, obviously somebody has talked to DCH because they quote in the last paragraph how the bill could incentivize other providers to go after care and so forth, and so it is sort of a statement of saying they're not in support of it unless, so I may have taken that to add to what I thought I heard you say, so I'll correct myself. Other questions? Representative Rogers.
Madam Chair, that was the same question I had on that last paragraph, so.
Okay.
But to Representative Carson, are you going to let your witness make any comments?
Absolutely.
Okay, I'd like to hear for her for a few minutes.
We'll test out her speech ability. Bad joke.
Well, in I guess response to your comments, I wanted to say two different things. One, I'd like to say that there's a special waivered program in the state of Georgia for children with disabilities. So we do have a higher percentage of Medicaid children on our caseloads just because these children that fall under this waiver program have private insurance as well as Medicaid as a kind of a backup for when their private insurance doesn't cover. So that does make our percentage of Medicaid patients higher than I would say the typical medical provider may see. So for a private practice, it is really important to have these providers be able to see all the children that come through the door. So for us, it's very challenging to have a clinical fellow working in a private practice because you have to really limit who they can see. If Johnny Smith calls up and has Medicaid, you have to say, well, he can't go to whoever because even though they have an opening at the perfect time for this child, they don't have a Medicaid number. So it's just very restrictive to private practices and outpatient hospital clinics to hire clinical fellows right now. So.
I'm curious, when we talked about the other surrounding states,
Yes.
how many, and the supply and demand, how many people, clinical fellows do we have probably in the state of Georgia, and how many come out of school every year and after all the training? It's a...
Okay, well, I know I did a little research on the Secretary of State's website, and in Georgia, there's 3,200 and some odd licensed speech-language pathologists. As far as clinical fellows, I'm not sure I brought the number with me. It's definitely less than 300, somewhere around there. And as far as the other states around us, 4 out of 5 of the surrounding states allow it. I'm sorry, I forgot what the rest that you had asked me was.
No, that answers
answer
you.
it?
We have 3,000 speech pathologists, and I mean, I knew we were Southern and had trouble sometimes with our speech, but...
God talks like we do.
Yeah, yes, he does. You mean we have a demand for 3,000 speech pathologists?
And there's more than that. That's just those that are licensed. That's not those that are working under a Department of Education certificate.
Wow. 300 fellows. Oh, Representative Pack.
Thank you, Madam Chair. 2 questions. One is this interpretation or the policy adopted by DCH in statute, is it something that they could adopt as an agency, or is it something that's required, the statutory change is required? Because I was looking at the bill and looking at the section you're replacing, it doesn't seem to have anything to kind of address that.
Representative Pack, I believe it is more of a interpretation, a regulatory interpretation. We would like to make it clear in code that clinical fellows are eligible for the same, just as a speech language pathologist. To answer your question, I don't think it's specifically stated in code such that we would have to replace it. This is more clarifying in code the medical reimbursement, the Medicaid reimbursement, I'm sorry.
And they are specifically allowed in the federal guidelines for Medicaid services.
Has your organization tried to work with the department to get it changed?
We have tried for 4 or 5 years at this point to get this changed, and they refuse to change. So that's why we've gone this route.
What was their reasoning behind refusing to change it?
It was similar to what they put here in the fiscal note, that they didn't want to open it up to other provisional licenses, but when we look at the data on the Secretary of State website, there really are no other provisional licenses that would be similar to ours. So it doesn't seem to be an argument that we feel stands up.
Madam Chair, I would like the department to kind of answer that question. I'm kind of curious as to why they would take a position like that.
Okay.
If it can.
Yes, sir. To speak to the fiscal note, the last paragraph speaks about the provisional or license of restricted of any kind. So say a physician, for example, had a board order out on their license. That person is ineligible to participate in Medicaid. It's not an analogous situation by any means. This is an educational difference. But this would be the only professional type license that the department would be reimbursing for that was not a full unconditioned license with no order on it.
See. Thank you.
Yeah, Representative Watkins.
Thank you, Madam Chair. Could we just get you to clarify that a little bit more? So you are reimbursing, you're not reimbursing other folks who have a provisional license, or?
No, sir. It's my understanding that we will not credential anyone as a Medicaid provider who has a provisional or a license with an order against it.
The order against it. Certainly none of these would have any orders
Certainly,
against
no, I'm
them.
not saying that those two
Right.
situations are the same.
So are there other, I mean, residents or, I mean, the first year intern, PGY1, postgraduate year 1, they have a provisional license. And they're, so they get Medicaid reimbursement, or their attendings billing under their name? How does that work?
If it would please the committee, if I could follow up with you guys so I could have everything in black and white on that particular issue, because I'm afraid I'm not the best person to speak to it today.
Well, and can you ask, I mean, are you telling me that a dentist or a physician who might have, the board might have decided they weren't keeping their records quite right or something like that and had a minor thing that they'd been, corrected for, would not be able to continue to see Medicaid patients?
Yes, ma'am. If the board decides to take a corrective action against somebody or puts an order on their license, they tell us those individuals that need to be restricted, and we remove them from the program until the order is lifted.
Okay. Oh, it's some kind of, okay.
But we rely on the individual professional boards to inform us of those decisions.
Right, but none of these, like you said, that's not a analogous situation. None of these have provisional licenses, or their license are not restricted because of some drug use or whatever. This is that window of the 6 to 9 months that they have where they're under a supervising speech pathologist, right? Correct. So now, does the billing, is that there's no billing allowed? There's no billing. So they're not allowed to bill under their supervising speech pathologist.
They're not allowed billing for two categories of service, Dr. Watson. One is on an outpatient therapy basis from an outpatient hospital. Second is in a private setting, such as a firm, a private small business providing speech pathology services. Those two categories of services, clinical fellows are not allowed to seek Medicaid reimbursement.
Representative Pack, I'd like to answer your question with something that I was told when I was asked when I first ran for office if I believed in term limits, and I not come up for me before because I never planned to run for office when I did, and I talked to Senator Coverdale and Senator about whether term limits, and Senator Coverdale told me that the one thing that he had learned from being in Washington, that if you were going to term limit the legislators, you better term limit the bureaucrats, because if not, they would just outlast you and do exactly what they wanted to do and interpret the law they wanted to do. And I think that happens on many of the laws on the federal thing, and I think it's exactly what has happened here. And Mr. Dudley has been in this area for quite a while, and we have had several problems. Like for what I mentioned to him, and I still have heartburn, is that if you're an epileptic, they actually put out a thing where you should have to fail twice. And if the epileptic fails and has a seizure on their medicine, they take away their driver's license, they can't work and all that before they can have what the doctor's ordered. So I think we're running into a bureaucrat with an interpretation of their own rules. Representative Kidd.
Thank you, Madam Chairman. Follow up on Mr. Tatt's question. You're not currently covered, correct? You're not Medicaid currently does not cover you.
Some services.
The fellow, it covers some of the services of the fellow?
Yes.
So what you're asking us is to tell Medicaid to cover you. And if we do that, then Medicaid has got to go ask the Appropriations Committee for the funds to cover you. Is that correct?
Well, we don't believe there would be any, as per this fiscal note of Representative Kidd, we don't believe there would be any fiscal impact. We're not talking about additional services, and we're definitely not talking about higher rates. What we're talking about is, let's say, for example, I'm just going to throw out numbers. Let's say there's 100,000 kids in Georgia that are getting speech pathology services through Medicaid reimbursement. Okay, and there's 3,000 speech pathologists in the state. We're talking about expanding not the 100,000 of eligible patients under Medicaid. We're talking about expanding from 3,000 to 3,300 the number of licensed or some speech pathologists plus clinical fellows that can serve that same pool of 100,000 people. So we're not talking about additional costs. We're talking about additional providers to provide the same services as we're doing right now.
Thank you.
Did I make that clear, or did I say it too much?
You made it very clear. Thank you.
Representative Harden.
He has left, ma'am.
Okay, Representative Reinders.
Thank you. I just want to follow up. You said, going back to Representative Pack's question, you said that the department hadn't allowed you to do this. You've been asking for 4 or 5 years. Is there someone that can tell us why they haven't allowed it? And let me, I'm going to put a part B and a C to that. If it's not going to cost the state any more, and it's going to increase access, then why would the department not want them to do it?
I'm afraid I don't have a good answer for you, Chairman. I was not involved in those decisions personally and wouldn't want to speak to them. I'd be happy to follow up with the committee.
Is that it?
Yeah, that's all I got.
Representative Clark.
Thank you, Madam Chair. Just trying, as I'm sitting here trying to understand what the logic may be for not covering those two scenarios with clinical fellows of outpatient and private setting. Would part of the argument be that they need supervision, and that in those two settings they're outside of that, with outpatient and private?
No. Under the licensure that they currently have, they're required to have supervision through that licensure. So no matter what setting they serve in, they're still required to have the same supervision.
Same supervision.
So I think what we're saying is clinical fellows, through those 4 categories, Representative Clark, in the 2 categories that they are allowed to seek Medicaid reimbursement, and the 2 that we're asking for in addition, and under all 4 scenarios, a CF is serving under the supervision of a speech language pathologist.
Okay.
And that's actually part of their accreditation process.
Thank you.
Okay, that's all the questions. Representative Rogers?
Madam Chair, I just want to thank Jesse for being here. Jesse is a good ally for the department. Jesse, we're not picking on you, so he's good about responding back to us.
Right. Representative Roger, Jesse worked for me, and I have great respect for his knowledge. I consider him somebody I've helped grow up through the system, but that doesn't mean I can't still pick on him when I think the department's wrong. But we're right. But he's very knowledgeable, and he works well with us, and he falls on his sword when he has to stand up sometimes for the department. Representative Jaspers, you have a question?
Yes, ma'am. Thank you, Representative Carson. I'll show maybe my knowledgeableness of this part of this, but when you're underneath the supervision of this speech language pathologist, are they not billing for their time when they are with the other person that's under them? Is there not how's that billing work?
The clinical fellow is treating independently. They have 6 hours of supervision every 3 months. So it's very minimal supervision. So no, they're treating separately, and only 6 hours every 3 months do they get observed, and then that time is only billed by the treating therapist, which is the clinical fellow, not by the supervisor.
Okay.
Okay, thank you. Okay, that's the last of the questions. What's the pleasure of the committee? Representative Watkins?
Madam Chair, I recommend that we do pass.
I have a motion to pass, and I have a second. Okay, any further discussion? Okay, everyone in favor of the passage of House Bill 240, LC 334975, say aye. Aye. Everyone opposed, say no. All right, the ayes have it. That wasn't so bad, was it, Representative?
It was better than a dental bill. Thank you, Madam Chairman.